Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
How many of you eat shrimp?
I do.
There's an interesting article on the nutritious aspects of shrimp, and also the fact that, as I think many of you know, a lot of people are allergic to shrimp, so sea products. But there's an article talking about how nutritious shrimp can be, and the fact that they're low in saturated fats, which is good for you, and they're high in protein, and they have selenium, which is an important product. Hey, Buchanan, you want to get started and put this?
If you don't mind, I wanted to pull up an article from last week that we missed that
Okay.
I like. Okay. Let me see if I can get back to the home page here.
John Buchanan, what does your shirt say?
It says I'm somebody's type.
Blood type.
Okay.
Blood type.
Oh, okay.
I hope you mean blood.
I was just checking. I couldn't see the bottom half of that shirt.
Oh yeah, that was it's interesting. They have a number of health approaches that we as physicians don't talk much about. Tai Chi and yoga fit into that category, but they are very good complements to health, and people who do yoga can actually appreciate it. Any of you do yoga?
I do.
I did it one time. I miss it. I need to get back to it.
Mm-hmm.
I enjoy
I
it.
have tried it. Never stuck with it though.
I never tried it. Is it nice?
It is
It's
relaxing.
It is
Hello.
relaxing.
Hello.
Yeah, I started a couple
Lauren?
of years ago, and
Hey, Laura.
Hey, I did not receive a invite.
Hey, John. Laurie said she didn't get an invite. Would you send it another? You were on the list, so I don't know how you didn't get it. So he'll send it to you again. Okay.
Thank you.
Okay.
yeah, I started doing yoga a couple of years ago, and just once a week in person, of course, on Wednesdays. And now, since the pandemic, I've
Right.
been doing it three to 4 to 5 times a week on YouTube. I can do it right from my house, so it's very convenient. If anybody's interested in my my yogi person, I can send it to you. You'll have to let me know if you're interested in that.
Send it to me. Janice.
Okay.
Okay.
Well, I think that there are many aspects of yoga that fit into how it affects positively health, and it's probably one of the most often recommended complementary. That and Tai Chi are probably the two commonest that are recommended, and the positive impacts upon all aspects of health, especially mental health, certainly voluminous, actually. Yeah.
I started doing, my wife and I started doing Tai Chi. I couldn't remember the forms. You know, there's a lot of memorization you have to have for Tai Chi, as well as body control.
Oh. You never know what happened.
Well, I think that yoga and Tai Chi are the commonest of those that are recommended because there's little question that they improve all aspects of your health. If you can learn and understand all of the aspects of it. But some of the aspects of yoga include very high temperatures, right?
There are some types of yoga, yeah. Also, I went to a laughing yoga class once. It's a bunch of different kinds of yoga, yes. They have the hot yoga where you have hot rocks and you sweat, but no, I don't do that kind.
This is an article that may not be of merit to many of you because you may not have any heart problems, but there are a number of people, as you can read, who have atrial fibrillation, which means that the heart is not beating, it's not syncopated, and it's an arrhythmia so that the beating is out of sync. As a consequence, you have the likelihood of having strokes and other complications. And so there are a lot of myths about it. And this is an article that talks about the myths and the ways in which they're not operative.
Wow.
And one of the myths is that it is curable.
Hello?
Hey, did you get it yet?
I have not received it yet.
And Tatum, did you send the link again? Because she said she still hasn't received it.
And
Yeah, if her email is lori.wilson@howard.edu, that's what I sent.
Yes, and I actually sent an email to you to that request. Okay, it just showed up right now.
Okay, great. Okay.
Okay.
She
All right.
just got it.
Got it.
Okay. We just look forward to seeing you. Yeah, yeah. Any of you have any heart problems?
No.
Okay, that's interesting because you usually find somebody who has heart problems, but anyway, these are some of the myths about it. Since none of you have it, you probably aren't interested in it. But it's a problem that requires you to be put on blood thinners to prevent the likelihood of clots.
Good morning, everybody. My grandson, this is Betty.
Yes.
My grandson was born with crisscross heart, but he isn't having any problems. I don't know. I'm sure you're familiar with it, Dr. Callender, but other people may not be.
Okay.
But it has nothing to do with this.
No. But anyway, this is only an issue if you have it because it causes you to be more likely to have blood clots. And therefore they have to put you on blood thinners and other ways of treating it. It's an arrhythmia that requires cardioversion in many instances and special medications. But it's something that is fairly common. What is interesting is that as they talk about physical activity, that sex is a good, although many people have died after having sex. Sex is a good exercise to be involved in. Yeah, it's thought to be heart healthy, even though it's been the last act of many men. Okay. All right. Health benefits of coffee. Many of you drink coffee, I guess. Huh?
Mhm.
And
Yes.
what we're talking about recently is the positive aspects of coffee. Oh, Dr. Wilson is with us, so why don't we let me introduce her and then we'll.
I was actually, I don't mind sitting in and learning something.
Well, but the goal today is to learn from you.
I always learn from Dr. Callender, always.
Okay, all right. Well, Dr. Wilson is a very special person who's, well, I've known for too many years to relate, but she's a role model of a great, compassionate, caring physician who loves her patients as well as her colleagues and the people who she educates and trains. In addition to that, I'm going to let you talk about whatever she wants to talk about because she has a fascinating life story as well as a fascinating specialty. So she is a full professor of surgery now, and we're proud of her. And she has many more miles to conquer, and we look forward to her presentation today. Thank you for joining us. We're really thrilled to have you.
Well, thank you so much for the kind words. You know, it's always amazing when other people describe you and you're thinking, who are they talking about? Is that me? But it's such a blessing to be here, of course. I really struggle with kind of how to present. You know, I don't want to be too formal because I think it's an opportunity for us to learn together. And I always want to give that opportunity for us to reach out. And if there are any questions that you have along the way, please ask. This is a special month. It's a special month for me. It is Breast Cancer Awareness Month. And so thank you for having me here. It gives me some context and some theme to begin with. I always like to begin by really grounding ourselves in fact. When we think about breast cancer, about 250,000 women each year are diagnosed with breast cancer. When we look at women who are reflective of my ethnicity, about 40,000 women are diagnosed. When we think about breast cancer, the concern always is when it occurs, why is it occurring? There are definite risk factors that we know about breast cancer. There are definite things that we should be aware of when we think about breast cancer. There are things that we can control, and there are things that we can't control. When we think about breast cancer, the median age or the average age of breast cancer in white women are 62. The average age of breast cancer in Black women is 58. And so when someone has a breast cancer below the age of 50, like I was diagnosed, then usually it's a red flag because we know that we expect breast cancer to occur as we age. And so when you have it sort of earlier, then the things that you have to be concerned about is your family history. Does your family history seem to have an impact overall on why that cancer may have occurred? And so any woman who comes to me, the things that I say you can't change, of course, is your age. As we age, we're at higher risk for breast cancer. One of the things that we know about breast cancer is it happens more commonly in women, but not only in women. About 1% to 2% of the breast cancer cases in the country, about 2,000 patients, happen in men. So it occurs in men as well. However, those are the things we can't change, right? We can't change those things. And so it is important to know those things. It's important to know our family history. Can't change our family history, right? But it's important for us to talk about it. It is something that I have found along the way that is very difficult for families to oftentimes open up and share about the medical problems that they may have. Whether it is a cancer that occurs in the breast, a cancer that occurs in the colon, a cancer that occurs in the prostate, the most common cancers that we experience, a cancer in the lung. Oftentimes people will go through it alone without sharing it with their family members, not wanting to burden them with the diagnosis. And I think one of the things that, if I could change anything, it would be the openness that we should have about our healthcare and the way that we share it with our family members. And hopefully knowing that it can be done in a way that is allowing us to share without worry that there is any level of negative impact from that. And I know that there can be, and I know that I've seen it, but the vast majority of experiences of our patients are that they are supported, and that they are, by the fact of sharing their story with their family members, that they gain something in that. They strengthen their relationships. They give information to their family members who oftentimes are younger, and give them power and really empower them to know what to do about their bodies. I spend a lot of time just reading both surgery and not surgery. And I was reading about Mary J. Blige, and Mary J. Blige was, as you all know, is a singer. She's been singing for 20 plus years. And one of the things, she finally is coming into the age of when she should have her mammogram. And one of the things she said, a couple of things. She said, I didn't know anything about a mammogram until I went to my GYN when I was 40. I didn't know that I was supposed to have a mammogram, and no one in my family ever told me that a mammogram was important. Knowing those simple facts about educating our families about the things that we should do to make sure that we can be around is so very, very important. So we talked about the things that are things that we can change. Well, I mean, we can't change our family history, being our gender. We can't change those things, aging. What are the things we can change and do have an impact on reducing the risk of cancers overall, and especially breast cancer? And so the things that we can change is exercising. Exercise in itself, I was catching the tail end of what Dr. Callender was talking about, and healthy exercise. And I oftentimes, part of what I always ask my patients in every time I sit down with them is, what exercise are you doing? And by and large, everyone discounts walking. No one says walking is something that is an important exercise, but it absolutely counts. I just like, take credit for your walking. And walking absolutely is a part of healthy awareness, wellness, and exercise that can reduce the risk of cancers and can reduce the risk of breast cancers. We also know that things like our diet, obesity, we know that changes in the amounts of healthy and unhealthy fats can have some impact. The amount of alcohol that we drink. There is a limit to the amount of alcohol that is healthy. For women, we typically say 1 glass per day, averaged over the week, is what is recommended as our limit. And so all of those things, I think, are things that are important. Are there things that we should be doing to make sure that we are also prepared? And it is making sure that we are getting our information from well-established sources. I think that one of the things that we may suffer from, and we've seen this in COVID as well, is misinformation that is put out and disseminated about a particular disease type. Breast cancer in itself is curable. in itself, caught early, is absolutely something that we can get through, can cure, and go on with our lives. However, one of the things that we know is that if we don't do our prevention, if we don't do our mammography starting at age 40, that and do it every year, that we are at increased risk of finding breast cancers later with more difficulty in the ways that we treat breast cancers. And so that is my little mantra that I always give about breast cancer. It is the basic facts of age, things that we can do, things to share with your friends, your family. How do you support them? Let's make sure that family history and sharing is something that we are role modeling for our family members as well as our younger members of our family, so that they know that open discussion about health is something that is expected of us and can be done in a way that helps us to maintain a healthy lifestyle. Switching over to my life story, I am blessed to be born in the Tidewater area. I grew up in a small city named Portsmouth, Virginia. Lots of HBCUs were near Norfolk State, near Hampton, near Virginia State. Just a wonderful upbringing. I grew up in a community that was a Black community that was actually designed around being empowered for a middle class, retired group. And so I reap the benefits of that. My father retired out of the military after 35 years. He settled back in Portsmouth in my community, which is named Cavalier Manor. We had over 40,000 Black people who lived in my community. And the expectation from our parents was that, of course, we would do better in what we were going to obtain than they. And that means that they sacrificed for us. That means that they made sure that everything that was available for us could be. And I'm blessed to know that my parents sacrificed for me. I'm first generation going to college. I'm first generation going to med school. I'm first generation being able to represent our family in a way that my father was a great provider. He was wonderful in providing the structure in our family. My mother was a brilliant woman who never went to college, but did all of our investing, did all of our taxes, did everything. Just an amazing woman. And so I had great role models growing up. However, I did not know how to get to the end point of wanting to be a surgeon. I remember, I'm not sure if you guys remember the show MASH. MASH was the show that came on kind of in the 80s or so. And there was a surgeon on it called Hawkeye, and he knew how to operate on everything. It was, I think it was about the Korean War, and he was over in combat, and he knew. And so I was 7, and I said, I want to be Hawkeye. I want to be a surgeon. I didn't know how I was going to do it. I know the very first time I told my parents that I wanted to be a surgeon, they did not bat an eye. They said, sure, honey, absolutely. If that's what you want to do, that's what you're going to be. Thank God that science and math are in my wheelhouse. That's something that works for me, or I'd be doing something else, of course. And but thank God that I had parents who felt that girls could do whatever they put their minds to, and they supported me academically through public school, through coming to Washington, D.C. I did my undergrad and med school at Georgetown, and then I met my family at Howard. I remember the very first time that I had the opportunity to see somebody who reflected what I wanted to be and was me. And so I was sitting in my little cubicle. I used to study every day, same time, same place. You know, you could find me. My friend came by and said, you know, there's this surgeon who's coming over from Howard, and he's going to give a talk. He was like, do you want to come? And I was like, ugh. You know, I have got to study. You know, I got this plan already in place, but nonetheless, got my little books, went to the library space that he was giving a talk. And that's where I met Dr. LaFall for the first time. And Dr. LaFall, for you all who may not know him, is a surgical oncologist. He's a former chair as Dr. Callender was. And he was the first representative of Howard, the first representative of a surgeon who reflected everything of what I thought a surgeon should be. And they looked like me, and gave me the ability to know that this was and potentially could be my path. And so I was done. I was like, okay, I'm going to Howard. I know that I don't care what I have to do. I'm going to work hard. I'm going to, you know, as we do in oftentimes in the South, put your head down, you work hard, you work hard, you work hard. You expect that God is going to bless because you pray about it. You do what you're supposed to do, and you think that your goals will be met. And thank God He blessed me with the ability to spend a month initially with Dr. LaFall, and that was just before he became president of the largest surgical organization in the country, American College of Surgeons. And it gave me the opportunity to go to Howard and to see this wonderful opportunity of surgeons like Dr. Callender, who were at the top of their game, at the top of their field, teaching, addressing, educating, and expecting me to be my best, no matter where I was. And that hadn't been my experience before. Unfortunately, in high school, yes. When I got to my undergrad and medical school experience, it was more about, okay, you're the Black student here, and you know, we expect you to show up. We don't expect you to be spectacular. We don't expect, you know, we expect you to be here. And that was, though I'm sure that the expectation from them was not, that was the vibe that they were giving. But unfortunately, it was the context of how many of my friends and I felt. And so I went to Howard, and it became about Lori, me showing up, being prepared, knowing what I was supposed to do, being given a voice. And I really felt like I had no voice until I got to Howard. And so I got to Howard. It gave me the opportunity to train at the preeminent HBCU, the preeminent institution in Washington, D.C., gave me the opportunity to really showcase who I was. And after that, it was no stopping me. I felt that I had the opportunity, I had the support, and I had the most amazing education that I could have had. And all of that led to where I am today. I did my fellowship out west, finally came back to University of Connecticut. I ran their division of surgical oncology. I was in charge of melanoma, in charge of GI, did a tremendous amount of research while I was there. And then the opportunity came open to come back to Howard. And there were a couple of reasons why I wanted to come back to Howard, because my entire career, or my entire life, my community poured into me. And my expectation for myself was that I was going to come back and serve.
It's just scanning it out. No one really is.
I mean, you know, I'm just saying, if you're not interested.
And in that, it gave me the opportunity to back and serve at Howard. And so the opportunity came up, and about, gosh, I've been here going on my 11th year in January. So 11 years ago in January, I came to Howard, and it gave me the opportunity to educate students, to educate my community, to spend time with patients that I felt really needed time to really process the word cancer, to really process the understanding of what the expectations of the disease was, to understand what the next steps would be, to make sure that everything about their diagnosis that they understood, because we know, the literature tells us, we know that when you are well educated and you make decisions on well-educated decisions, you're happier. You are better served. Your family's better served. Your community's better served. And so knowing that, I really set out to do these, take these opportunities to do community service, to make sure that my patients were educated, that health literacy was a big part of what I was doing. And then a year, 2 years into my time at Howard, I had my son, who is the light of my life. He is now 9 years old. But when he was 1.5, after, you sort of getting back on, I had my son, I stayed out, I breastfed. Breastfeeding is a good thing. It's healthy and actually also reduces risk for breast cancer. After I stopped breastfeeding, I noticed that one of my breasts didn't go down. And of course, in my world, I knew that that meant that there was something that was wrong. And so I went for a mammogram. I went ultimately then for a biopsy. And what I found out was that I had breast cancer. I had a 1.5-year-old son. I had just gotten into the job, my dream job. I always say that, around people who I loved and cared for, and loved and cared for me, and really inspired me every day.
Did you wake up?
Say that again. Oh, and so I was given the diagnosis. First thing I did was to call my husband, and we decided that we were going to fight. And so for us, that fight meant that I would start off with chemotherapy, so I lost all my hair. It meant that I wasn't sure that when I lost my hair, my son would actually recognize me, but he did, of course. It's amazing the small things that you go through with the diagnosis that no one ever talks about. The changes in the tones of your complexion. For me, my palms actually turned very dark. My tongue had dark spots on it, and that was just part of the process. It was part of the things, but oftentimes it's not something that's inclusive of telling Black patients, what do you expect for what your ethnic background is. I had had chemotherapy, ultimately had a double mastectomy, had my reconstruction that was done. And one of the things I don't often talk about, but I think it's far enough away that it's not so difficult for me to talk about, is when I had my reconstruction done, there was for me, I was tired, I was worn down. And I know that there's oftentimes expectations that you're going to be strong, and that you are going to have the better face, and that what you're going to show everybody is that you can do this, and that it is not going to be a problem. But there was this moment that I was just so tired. And I should have known that there was something that was going on. And I did know. We always know our body. And, you know, when people talk about advocating for yourself, it is not easy. I found it hard in this one moment. And I called my plastic surgeon, and this plastic surgeon was not at Howard. I found that one of the things I started at Howard, and one of the things that made it difficult for me was that I grew up with everybody that was taking care of me at Howard. When I got my MRI at Howard, the young lady who was my MRI tech, I remember when she started, and she was there, tears streaming down her face, because she knew I had a diagnosis of breast cancer. And I felt in that moment, I had to say, well, you know, it's going to be okay. It's going to be okay. I'm going to be okay, you know? And so I felt that over and over, I was managing other people's emotion. I had my biopsy done, same thing. My pathologist was there, and he was there crying when he saw that I had cancer cells in my lymph nodes. And I know that was not the intent, that the intent was not to not give me the ability to be a patient, and for me to cry, and for me to be weak, and me to be vulnerable. And so I found that it was very difficult after a time. So for my reconstruction, I went to one of our neighboring partners. This person on that Friday, I remember calling and saying, you know, I'm not feeling well. There is something going on. And this person was like, oh no, you'll be fine. You have an appointment on Monday, right? I'll just see you on Monday. And I was like, no, I really think I need to be seen. And he was like, no, I think you're fine. You know, what I hear from you is just kind of standard. Long story short, the next day I was in the emergency department with low blood pressure. I ultimately was admitted to the ICU. I lost my reconstruction. And it was all because, as a Black woman, it may not have been that I was a Black woman, but I was dismissed. He did not hear that I was in distress. He did not hear that I needed to be seen, and that he didn't take into consideration, this is what I do for a living. And so if I am coming to you with these concerns, that at least you could value enough that there might be something that's there. And I talk about that because I'm embarrassed that I allowed someone to take away my agency. I allowed someone to take away my advocacy. And I just went along with it like, okay, I guess I'll see you on Monday. I'll take my antibiotics. I'll see you on Monday. Monday came around and I was in the hospital. Monday came around and the next Monday I was in the hospital. You know, it comes back to it never being easy what we tell our patients to do. It's never easy for us to it's never easy for us to share and to live up to every standard in every moment. And so after that, it gave me the insight that I try to never discount my patients. I try to listen to what they bring me. And I try to work together with them to make sure that what happens is something that we both come to agreement on. Ultimately, I lost my reconstruction, but my life I was alive, and so I was happy about that. Ultimately, went on to have radiation and therapy, hormonal therapy, which are pills that you take afterward that are supposed to reduce your risk. So I had done everything that I was supposed to do. And that's sometimes the difficult thing for patients. I had watched my weight. I had been very good about exercising. I had been very good about trying to limit my alcohol, trying to live a good life. Did my mammograms, did my all the things that I was expected to do. And this is sometimes a very difficult thing for patients to see. And it still happened. I still got breast cancer. And, you know, sometimes people say, why me? And my mantra is, why not me? God said he will always be with me. So he was with me through all of this. And he strengthened my relationship with my husband. He strengthened my relationship with my family. He strengthened my relationship with my community, because during this time, the support was tremendous. Whether it was the support in my family that is my work family, my family that's my home family, everybody was there for me. And it was not easy to share that I was a patient. It's not easy to share that I had to give up my thoughts of being in control and turn that over to someone else. It wasn't easy letting my husband be in control of everything, helping in, you know, with our son and all the things that I felt were my responsibility. But we got through it. And ultimately, I spent the next 5 years traveling around the country, along with working and educating people about the things that we should know about cancer, the things that we should know about breast cancer. How do we make our lives different? What are the things that are important? And, you know, at the end of the day, for me, it was about finding the joy in my life again, finding the things that make me happy, whether it is sitting down with the patient, like I was yesterday, just talking about all of the wonderful goals that they've set for themselves, whether it is supporting our students or our residents in what are their next steps, and young people in the same position that I was in, where they were first generation and they don't quite know how to get there or how to choose who they are going to be, but ultimately need that mentorship and support. So 5 years went by, 6 years went by, and usually we think about 5 years being our time frame where you think that you're really good. You know, 5 years, you've made it 5 years. In year 6, I went on a cruise with my family. This was in 2019. I came back and I had this really excruciating back pain. And so I went to get that checked out. And what I found was that my cancer was back. And this time my cancer was in my liver and in my bones. And it gave me a different fight to have, a different discussion to lead. And that discussion was the discussion about being metastatic, stage 4. I think that that's a scary term for many people, especially when we're dealing with cancer. For me, what it meant was, it was educating people about that everyone is not the same when you are metastatic. It's a grouping of patients that end up there. About 1/3 of breast cancer patients, no matter where they start, will end up being metastatic, which means that their breast cancer has moved from their breast to other parts of the body. Brain, lung, liver, or bone are the most common sites. And so for me, it meant that I needed to begin to educate my providers that my decisions were not going to be the same decisions as someone who may have hit all their milestones. They've raised their children. They've had all of these great things happen in their lives. They're settling down and in the end, and may want a different path for their metastatic disease. For me, I was willing to do just about anything within the standards of care to make sure I'm here as long as I can be. Because I had at that time, I had a 6-year-old, and I was a 7-year-old, and I was wanting to be a mom until he goes to grad school, honestly. I want to see him grow up, graduate. I want to sit on the porch with my husband and have a retirement that is the benefit of all the hard work that we put into our lives. I've known my husband since I was in medical school. He's not a clinician. He actually is an engineer, but an amazing father, an amazing husband, and ultimately has taken care of me well. And so ultimately, we got to this place, and what my second mantra is that clinical trials are good in light of what your needs are. For me, the clinical trial that I got in made my disease in my liver go away, and it stabilized the disease in my bone. That is what you are looking for in stage 4. You want to stop things in their tracks. And my clinical trial did that for me. I think that there's a lot of mistrust in clinical trials and what they can do. However, clinical trials absolutely can be very useful, very sustainable, and very directed to improving the healthcare and extending the lives of patients like myself. Are there difficult things in clinical trials? Yes. And that is my third mantra. Clinical trials are not made easy. They talk about how Black people don't, in clinical trials, only about 17% of clinical trials are actually have Black patients in those slots. However, what we know is that clinical trials can be expensive, especially when Black women are disproportionately head of their households. That means that they have to be away from work, that they have to do more examinations, that they have to do more things that are really good for you, but oftentimes are not supported by the clinical trial. And those are things that we need to begin to voice and pressure these pharmaceutical companies, because they have the money to support patients in their goals of clinical trials, not only getting them to clinical trials, but making sure that functionally the clinical trials will support their financial needs, will support their needs for their familial needs, childcare, for all of the things that are necessary to make sure that they can participate in a clinical trial. And then when the clinical trial may be done, how do you transition into another clinical trial, which is not easy as well. And so here I stand. I was diagnosed initially, and I am 3 years into my diagnosis of being stage 4. I am doing well. My disease has been stopped in its tracks with the current treatment I'm on. I work every day. I love what I do. I'm able to really use my life experience to share and care for my patients, to help to educate my students and my residents, and hopefully will in some way have an impact on the way that the world views the way that they talk about cancer as it relates to Black people. Because I think that when I hear the language, it's harsh and it's scary. And I don't know why that has to be. Also, I think that it's important that the financial needs that are necessary are met, and that the voice of an empowerment that's necessary for us to be a part of changing policy and changing the direction of where we are providing this care should also be in our hands. And so I have hopefully many years to invest in this. I have a love for my patients, a love for my work, and a love for all of the mentorship that I've received. So my shout out, of course, is to you, Dr. Callender, for all of those moments that you allowed me to bend your ear, and talk about these moments and how to navigate the worlds that are new and particularly uncertain for me, especially as it relates to work and decision making in healthcare. And so in that, I'm going to end, and hopefully if you have any questions, I'm happy to share with you what my experiences have been, what I've thought about as a woman of God, as a clinician provider, as a caretaker, as an advocate, as it relates to cancer. So thank you so much for the opportunity to talk to you. Thank you so much for the opportunity to share. Hopefully the fact that this was a little less formal gives us an opportunity to talk a little bit more just upfront about the diagnosis of cancer and what it means.
Thank you very much for a spectacular presentation and giving us the insights into something that we wouldn't ever have been able to see or understand or even feel. Because I mean, you put your heart and soul into it, and we appreciate that. So the floor is open for you to ask any questions that you like at this point.
I have a question for you, Dr. Wilson. First of all, thank you so much for sharing your experiences. Wow, that's, I'm almost speechless, but your occupation as a surgeon for cancer, that must give you a perspective that is probably priceless for your patients. So do you still do surgery, or are you teaching more now?
So you're absolutely right. I think it gives me great perspective. I actually do surgery. I actually have 2 cases today, as a matter of fact, that I will be performing later on in the afternoon. But I see patients. I think that one of the things that has always been my goal is to be boots on the ground. I want to be close to my patients. I never want to give up that relationship. That's what drew me to wanting to do surgical oncology, the research, the opportunities to operate and to make significant change in people's lives, but also to be able to educate about what cancer is, and to answer those questions that sometimes seems really awkward, and so absolutely, I am able to do that, and I get a lot of chance to teach as well. So I'm
give me your name one more time.
One last question. With the technology that's being applied to the vaccines, do you see hope for cancer treatments coming from the mRNA technology?
What an astute question. Yes, that is absolutely. It's not tomorrow, but it is, I think, the technology that has been able to be developed absolutely will be used in moving towards the immunotherapy that you're beginning to hear about, using our immune systems to fight cancer. For there being areas of cancer that immunotherapy absolutely has helped, like melanoma, absolutely has helped. There was a thought that it would not work as effectively in breast cancer, but the industry has worked really hard regarding that. And now we are beginning to see the benefit of that work. And yes, immunotherapy and vaccine work is going to lead to long-term impact on cancer. I suspect that probably in the next 5 to 10 years, we're going to have some early stage work that begins to prolong life. And what we want to do is we want to make it into, if we can't make it all go away, we want to make it chronic. We want to make it like what we thought AIDS, HIV was in the very beginning. And now people are living lives as a chronic, that as being a chronic illness, like diabetes or something like that. And then ultimately, living a full life and then succumbing to something else. What we believe and what we know is that the technology is there. The work is ongoing. And I do believe that it's going to be impactful. But great question. That was a great question.
Thank you.
I have a question, Dr. Wilson. I also want to thank you for coming. Sorry about the mix-up on the link, but
no worries.
Okay. My question has to do with the surgery. I know that you sometimes have to remove breasts, and that must be a very, very sad occasion. So tell me about that. And do you do also reconstruction?
So we typically work as a team, and we know that that there are different ways that women attach themselves to their breast. And there are absolutely women who feel defined through their breast. And so the loss of their breast is something that's difficult. But then there are also women who are not as attached. And so it's not as negative as and impactful as one would think. And so just like everything else, it is the individual that you have to treat. And yes, there are women that we have shared in that experience, and it has been a stepwise process getting to the impact of what losing your breast is, because it never feels the same, because it's like something else in your that's been put on your body that doesn't have a feeling of what your normal breast reacts to. The sensitivity, all of those things oftentimes are lost, or they change. I decided not to get reconstructed. My husband and I decided that reconstruction wasn't as important. And so I'm not reconstructed. But no one ever tells me that they notice that I'm not reconstructed, maybe because I'm a small framed person. And I honestly don't feel lost by the fact that I don't have breasts, because so much of who and what my life is attached to isn't defined through that, and doesn't really make me feel less than, or that I've lost anything because of it. So what I found is that finding out what people are coming from, what they are expecting in their final outcomes, what attachment level that they have, and how do we get them through it. Sometimes people do need to have someone to talk to. They need to have someone to share this experience with. One of the things that we did not talk about, and not just because of loss of breast, but loss of lots of control and those sorts of things. Mental health and cancer is not something we talk about well enough. We don't talk about the needs of using just normal therapy as a standard for getting through any process that is devastating. This is traumatic. I mean, this is a huge event that happens in your life that oftentimes you are not prepared for by any other thing that you've ever gone through. And there's not something that is really in place to make you aware of how to do it. So mental health and utilizing therapy, not only for this, but just for the whole event, is something that I think is so important. And it's difficult, I think, in some communities because it's not as readily accepted. But it absolutely is very helpful.
Thank you. Thank you for that answer.
You're welcome.
Good morning, Dr. Wilson. My name is Rochelle Brown, and I'm a 6-year cancer survivor. And your story is almost similar to mine. When I was diagnosed, I had stage 1. And when you talk about Howard University, I'm a Howard grad. And I choose my doctors who went to Howard because of their care and their attention to me. I got rid of my internal doctor because I'm in Kaiser. And when I was diagnosed, she did not say, I didn't expect for her to call me personally, but just say, I saw that on your mammogram, if you got any questions, call me. And I was diagnosed in March. I didn't hear from her in July. I called my old internal doctor. I said, find me somebody who went to Howard. I said, because this lady's not talking to me. And I got Dr. Clayton. She's, I said, I don't have to come in, but I just know you on my team. And I had a very good team. And I give all credit to Howard University. I'm just telling you, they got the best. They don't let you out unless you're ready. So I'm just, I'm ecstatic. I had reverse thing. Now, after I had my chemo and radiation, my breast started to grow. So I talked to my oncologist, and he's very good. And he said, I said, well, let me try to lose some weight. I said, before I can get them reconstructed. Okay, I lost weight, but I had surgery on the left, but my right breast, hey, it started growing. I said, okay, it's just too heavy. It's just too big for me. I'm only 5'1". So my little team got together. They worked miracles on me, and I'm still here.
Yeah.
And I'm just telling you, I give all good praises to my team.
Thank you so much for sharing that. There were so many pearls in that I just want to highlight. Number one, having a team that you choose and is on your side. That is so, so important. I think that we don't emphasize that enough. I didn't even talk about it, but it is definitely one of the things I feel is so important. The fact that they listen to you, the fact that they obviously partnered with you. I heard the language that says, we sat down, we talked about it, we worked it through, that togetherness makes all the difference in the world on outcomes of how well patients do. And I can just tell in your voice how happy you are with where you are in your journey. And that is a credit to you, of course, doing the work, doing all the things, but also a credit to your team, because they did what they were supposed to do for you, making sure that all of those needs were met, those tangible and intangible needs. And so I'm so happy to hear your success story. Thank you for sharing. I just think that it's amazing, and God bless you, and with many years of health and wellness and sharing your story and testimony.
Yeah, even my barber participated. He was on the team because he had a person that he cut her hair. She wrote a book. He gave me her little kit. I had a village.
Yes.
Now, me and God had a talk too, because I talked in my kitchen. I'm in my kitchen right now. And and when I was had my last chemo, and I was feeling all bad, barely could walk. I said, Jesus said, get up out the bed, go on down there, take that medicine, and then crawl on back upstairs. This is how me and God, we talk.
I love it.
It ain't hard. It's not difficult.
No.
But you just, you have to. It's a village. It's a village. It's a village thing. As a matter of fact, when I was diagnosed, I was coming back from a conference, and my sorority sisters were in the car when they called and said, "You need to come back in." And my soror said, "Rochelle, I got you."
Mm-hmm.
All the way. And I just lost her this past July.
Oh,
and she was diagnosed with cancer too. But I'm just telling you, you have your people in there to support you, and it's the mental thing. Now, I didn't have a thing about, my boobies, because, they got, all the, bras and stuff. I wasn't attached to them, but just whatever would make me, and it's the mental thing. So that was the thing. And I had to call my old internal doctor who retired. And I said, well, this woman didn't do such and such. I said, here, I'm March, and here is July. She hasn't even reached out to me and say, okay, anything you want. But Dr. Clayton said, what medications are you taking? This is the side effects, explaining stuff to me.
Yes.
And when they sent me my packet, I said, here's my table. I read everything they said. What to do, what to expect. When I talked to my surgeon, she said, we're going to, first it was just do the lumpectomy and radiation. Mm-hmm. And then after they did the autopsy, they said, no, we have to change the course. This is what we have to do. I said, okay, I'm good. But my only request for them was, let's get all this stuff done and completed before Thanksgiving, because I don't want y'all to make a mess of my Thanksgiving. And hey, they made it work for me. I had my demands too, so hey.
Exactly. And your team sounds fabulous. And the fact that you were able to share all those things, and I love the story about your soror, and your sorors, and how they were invested from moment one, that they had you. And one of the things I am so thankful for is to hear that story, because we know that every person doesn't have that.
We were on Howard's campus just doing the mammogram thing and the COVID testing, giving shots. So you know who I am.
Absolutely. Thank you so much for your story. Thank you so much for sharing.
And Dr. Wilson, I think I met you because I think you came to Mount Zion Baptist Church and gave a speech on Breast Cancer Month.
I did.
So nice seeing you again.
Wonderful seeing you again. Thank you for the kind words, and thank you for sharing your amazing story.
Dr. Wilson, thank you so much for your wonderful presentation. And I think without using the words, you really amplified the importance of a cultural context. I've done a lot of work about health occurring within a cultural context. And I think that's one of the things that you really talked about, was the importance of understanding the culture within which a person lives, and how that has to be addressed in dealing with any kind of health issue. And I just appreciate the fact that you talked about it without mentioning the words, but it's just so important, and I really appreciate that, which is why I always choose a physician or any professional that looks like me. Because they understand me. I mean, they understand where I'm coming from. They know my diet. They know how I worship. They know how I live, how I do all those things, which are important in healthcare. And a lot of other physicians, because it's not taught, it's not even addressed in most medical school curricula, don't understand it because they've never walked in our shoes. So thank you. I appreciate that.
Thank you for bringing up you guys have just brought up so many amazing points. But you're absolutely right. I was in one of my office visits yesterday, and one of the things that always tells me that I am resonating with my patients is when they do something that is culturally something that other people wouldn't know or wouldn't expect to happen. And my patient was there with her daughter, and she started singing a song to me. And she may, in other environments, may have felt uncomfortable, but she was singing, God's been good to me. And she sang the whole verse to me, just sharing the fact that she was done with her treatment and how happy she was. And it just so warmed my heart, and just it was one of those moments that you could not expect. You could not say what about it was so amazing and spectacular. But it was one of the best moments that I've had in my career. Those moments where people are just sharing who they are, and I get to then be who I am. So I absolutely believe that cultural. Right now, we think of the cultural competency, cultural dexterity, cultural humility. There's so many terminologies to encompass that, but we want to make sure that it's reflected and it's respected in those moments where it might be so necessary to have in difficult times, that we know that we use those strength items in our lives, our culture strength, our religion strength, our ability to think about those moments in our lives that have gotten us here and have helped us through other difficult times, to be able to bring those to and comfortably share. So thank you so much for that. But I am right there in your wheelhouse. I believe it is so amazingly important. And I hope you're still doing that work, because there's not enough of it.
Thank you.
You're welcome.
Hello.
Hi.
Dr. Wilson.
Yes.
This is Betty Blaylock. Two things I wanna say. Presentation, of course, was marvelous. Thank you so much.
Thank
and
you.
I want to give you a little encouragement as far as longevity is concerned. My godmother is coming up on her 92nd birthday, and I believe she had breast cancer over 50 or 60 years ago. So I'm just letting you know that the longevity is there.
Yeah. Yes, exactly. And one of the things, there was a documentary called Ken Burns, Cancer, Emperor of All Maladies. It was done about 5 years ago. And I was the breast cancer patient that they followed in that documentary of many people. And one of the things that I told my medical oncologist was that I did not want to know prognosis. They had a discussion about what my prognosis was going to be. And I said, I don't want to hear that, because I don't want any limits put on what my prognosis may be. That's something that's between me and God. He knows how long I'm going to be here. I'm not going to listen to what you all think is going to be important. I'm going to do my part, and then we'll see and how long he blesses me. And so you're absolutely right. If I'm here another 30 years, that would be fantastic.
Great. And the second thing I wanted to stress was, I have a niece who has breast cancer, but I listened to your story, and it is so true with her. She is so private. She has cut herself off from the family. We communicate with her through her husband. She just does. So I am definitely going to, John, both of you Johns, or one of you, make sure I get this recording so I can send it to her, and maybe it will show her that she needs to share and be close to her family.
No
So
problem.
I have my husband's daughter, my stepdaughter, died 2 years ago from breast cancer. So I want my niece to do better. And I don't even know what stage she's in. We know nothing. So I just think that maybe she's a Howard grad. So maybe she will listen to your presentation and come out of her shell a little bit. So thank you so much for sharing your story so intimately.
Oh, thank you. And you're absolutely right. It is difficult. But it's so, I mean, let's just think about some of the stories and sharing that we've heard today about how the village has been so important, how people just pour out love and share in these moments. If there is a moment to actually be open and willing to give people opportunities to give their love back to you, what other, I mean, moment is there except when you have something like cancer or something really significant in your life? This is a time where you want your family close, where you hopefully want them to share in these moments and to take some of that burden away. But I know it's not easy. It is not easy.
Yes, well, Darryl will take care of making the video, Betty, and he'll make sure you get it.
Thank you so much. I'm on my way to a funeral, so if I drop out, that's why. But I had to say what I said, so that's why I put you on my phone, and I'm taking it with me until I get to the funeral home. Thank you.
Thank you.
Dr. Wilson, another question. Just in the last few days, I've heard on TV or seen on TV talk about PALB2 breast cancer. And I'd never heard that one before. Can you talk a little bit about that, please?
Yeah, one of the things we know about our cancers, we think about it as, where does it start? We then sort of move to, are there features about the breast cancer, like histology, you know, what do the cells look like?
Mm-hmm.
And then we then begin to more deeply look at what are then the molecular features. You know, we think about receptors, we think about proteins like HER2. The PALB2 has been one of those new targets that have been, we have enough data to know that as a target can be used to reduce the risk of it coming back. Because all the things that we oftentimes are doing is trying to eradicate, but also trying to eradicate and risk reduce. So it is one of those targets that's going to reduce the risk of it coming back. And it also has the great benefit of being a target. So a target means that we can use it to focus our treatment to. And when you do that, then it either kills the cells or it makes them unlikely to come back.
Now, some are more specific to certain ethnic groups than others. Now, everything I've seen with this, I saw nobody that looked like us, like me. I mean, is this something that impacts us as well, or?
So, you know, when I was talking about the clinical trials, why it's so important for us to be a part of clinical trials, because clinical trials aren't just treatment clinical trials, as you know. It is also about testing to see, is it similar outcomes in particular ethnic groups? And I suspect that the data isn't quite there yet because the numbers aren't great enough to say. And it takes more time. One of the things we know that when we started with, like, for instance, the genetic things that impact families and generations. In the very beginning, we only talked about Ashkenazi Jewish families, right? And then finally, we started getting more data, and we were able to then say that it does happen in Black families as well. Probably not as high as that, but definitely it is impactful. We sometimes lag just because it takes more time to get groups that are self-identify as being Black in these studies, and then having enough time, because usually you want a starting point, and then you also want a follow-up time frame, and that follow-up time frame oftentimes is 5 to 10 years. And so you have to get enough patients to know, to test, and then you have to have enough time to then follow up and see how it acts similarly or differently or not at all. And so that's is my impression of reading the data, that there is just not quite enough data for our group yet.
Thank you.
You're welcome. But it goes back to me just putting in my plug for, if given the opportunity, you don't have to be in a treatment trial, but you may even decide to give your cells, if you happen to have breast cancer, give your cells to a tumor bank so that they can use your cells, not to clone you, but to look at your cells as it relates to this disease process and maybe a particular marker. So it's not something that you have to do that's hurting your body, or you don't quite know what may have the impact, but can absolutely give information by providing it to the researchers. So there's so many opportunities for that, for us to share, but not have the worry that something untoward might happen to us.
Thank you so much for sharing that. And please, if anybody's having any kind of surgery, any kind of removal, please let Dr. Callender or me know, because WRTC can arrange for you to donate that tissue or those cells or whatever. And we do need it to make a difference in what happens to outcomes in our health. Thank you. Thank you.
Thank you. That's so marvelous. I think that we want to make sure we give everyone an opportunity to make a difference, even in moments such as going through a diagnosis of cancer.
Dr. Wilson, this is Carol Tatum. How are you doing?
I'm well. How are you? Good to see you.
You have thrilled my heart and everything that you said. And I thank Dr. Callender because he resembles you and you resemble him, and just what you've gone through the life. And first of all of this, whether it's a transplant, heart ailments, breast cancer, all of them follow the same paths. If you get over the denial and you start talking about making our community talk about it, get educated in it, and then choosing the doctor. I just had a friend the other day, choose a doctor that listens to you, no matter what your ailment is. Don't just hold on to that doctor because they got that title doctor and make them, when they dismiss you, you dismiss them. Dr. Callender already gave us a lecture about how to choose a doctor, and we had Dr. Robinson. And what do you say? Because before, I was never empowered about choosing a doctor. You just thought because they got their medical degree, and then let them know our culture, to see our faces. I went to a white school, and I wanted to see somebody when I came and just know that, because they taught me that Black people were ignorant, and if you went to a Black school, they didn't have as much knowledge as Harvard and Yale, the white schools. We have been brainwashed so long. And then your faith factor, which is the culture, that's what keeps us together. Dr. Callender also told us about that. Some of the people that he had with the biggest Bible beside their bed had the least amount of faith. Our faith in God is what really holds us together. And about needing the village, each one of us on this panel, all of you have blessed me just with your knowledge and have the struggles you've gone through and the happiness and joy. Even with Rochelle, in prayer, and Sylvia, all of us, and my brother, all of us have encouraged each other as we go through this. You are just a joy. I wish you could write a book. And if you did, I would take time to write it, just your book. And I know you go on circuits of talking and, giving speeches and everything, but you're just a joy. And you're something that every woman, everybody really needs to hear, because we can all relate. If we've been through anything that you have touched on so many different aspects, you've just been a joy, and I really enjoyed you.
Thank you so much. Oh my goodness. That I'm so choked up. My goodness. Thank you. I think that oftentimes we want to share and give back and know that our lives have purpose. And in that, I've had such great opportunity. And so I'll just say thank you. Thank you so much for that.
And thank you so much.
Thank you.
Dr. Wilson, this is John Tatum again. You had good start, because I knew Dr. LaFall and his work. Yes. And he was one of the greats that came through Howard. So you were trained well.
Thank you.
I heard he had a photographic memory.
It's amazing to be able to see all of the amazing talents that your mentors bring to the table, and realizing that some of those nuanced things you also have, and that you can see in yourself, and that you can share in realizing that you have value. And I think that over and over and over again, I don't get a chance to talk about it, but I hear so much from our young people, how either, feeling as though they're not worthy, that they kind of feel as though they're imposters, that, they don't, they're not as great as people think they are. And that they're not confident in why or who they are. And I am just so, I just wish that there was ways for us to emphasize to them how important it is just to be okay to be yourself. It's just okay for you to be who you are. You don't have to be reflective of what someone else's culture says you should be. And that if you don't reflect who they are, then you're not worthy. And so it's amazing how much of that I hear. But I'm very thankful that I had the opportunity to be mentored by Dr. Callender, Dr. LaFall, Dr. Mattori, Dr. Syfax. I've had the opportunity to really see them in action and to be at the heart of training at the height of their careers, because they taught me so much.
Dr. Wilson, I also want to ditto on some of the things, on all of the things that have been said. I have had a couple of scares with having breast surgeries, and what those have said about having a team and having a support system. I was young when I had mine. If it had not been for my support system, my medical support system, and my dearly beloved mother, it would have been a tragic experience for me. So yes, having that support system is very, very critical in overcoming and understanding the methodology and all aspects of your breast and all types of breast surgery. So thank you very much.
You're welcome. Thank you. Thank you for sharing that.
Oh, there's one.
Dr. Wilson,
Oh.
Dr. Wilson, I want to say thank you very, very much for your story. And I have actually been through, I have a girlfriend that was diagnosed with breast cancer, and I actually went through the entire process with her. And it's the strength of others and people, your support system and your faith that get you through. And I would have never realized exactly how much you have to go through, but the blessing is if you're strong, you got a good support system and your faith, but a lot of people don't talk about it. And so me going through it with her helped me to understand it and to be able and make sure that my daughters know this is what you have to do. And you don't have to hide anything, and it's okay. And yes, it's a lot, but as long as you can do it. And I just want to say thank you, because your story really, really has helped. And I have one question. I had a friend that was diagnosed with breast cancer in her left breast, and they did the surgery. And then she opted to have her right breast removed because she said, well, if you're going to take one, it's going to come back in the other one. Is that something that's normal?
So every patient comes to us with individual risk.
Mm-hmm.
And depending upon what that risk profile tells us, it helps us to make a decision about what the surgical, along with the histologic things that come along with it. It helps us make a surgical decision that is best for that patient. There is a definite risk of breast cancer happening in the other breast when you have breast cancer, just because the breasts are not equal, in that if you have breast cancer in one breast, the other breast is just like having the other arm. You know, when you think about your arm, the likelihood of something happening in the other breast is independent of having the cancer in the one breast. However, if you're at a higher risk profile because your family risk is higher, or you have a genetic predisposition that makes it higher, or there's something about that other breast that gives you a higher risk profile, then having the other breast removed is sometimes a good thing. There is a group of patients who, in their everyday life, their anxiety would be so great, and this is a very small number, but their anxiety would be so great that they could not function well without worrying beyond belief that breast cancer is going to come back in that other breast. And so putting together that person's profile, what their risk profile is, along with what their psychological risk is for well-being, may make you want to help that patient and do a mastectomy on the other side. However, what we know is it's been proven that the risk is not so great that the breast should be removed just because you have breast cancer on the other side. There's a lot of data that says that is really not a good way to practice, because you're still at risk for all of the things that potentially could happen. A risk of tissue loss, a risk of infection, a risk of there being recurrent scarring. All of those things are not something that are small things when they happen. And so when you have another surgery, you're putting yourself at risk for all of those things. And those things might also be ongoing. Poor wound healing, those sorts of things. And so there is risk that goes along with having the other side removed as well. And I don't think that oftentimes patients think of that as being something as high as it is and as important as it is. But you bring up a great point. The fact is that there's very little data that says removing the other side is actually helpful.
Many women have a hysterectomy after having breast cancer or having a breast removed. Is that
so
indicated or contraindicated?
It depends on your risk profile, your family risk profile. Oftentimes, younger patients who have finished their reproductive desires. However, when you look at their family risk and you do their risk profile, are actually at higher risk. You might do a hysterectomy because we know if you reduce the amount of hormone that is impacting the breast tissue that's left behind, that patient has a lower risk for recurrence. And so it is mostly contraindicated in just doing it just because. However, some women benefit from the having lesser amounts of hormones that are impacting the breast tissue, because we know that the ovaries and their production is what drives the changes that happen in the breast, and those many changes absolutely can lead to malfunction in development of cells and ultimately breast cancer.
Thank you.
You're welcome.
I just want to say one thing. Again, your talk today, your presentation has been absolutely wonderful. I think we all have learned a lot, but aside from the issue of breast cancer, Dr. Wilson, our paths crossed several years ago. My husband was a patient of Dr. Callender. And Dr. Callender, being the wonderful doctor he is, if you went to him for anything, pain in your pinky finger or your big toe, he's going to do a referral. And my husband had many health issues. It wasn't breast cancer. And I'll be honest with you, it was so much going on with him at that time. I can't remember specifically what this was. It was some sort of growth or bump on the arm or leg or something. And he referred us to you. And our takeaway from you at that time was, she seems young, but she seems very knowledgeable. And he liked you. He liked the way you presented yourself to us. But today was just overwhelming. And we all have a takeaway from this. And my takeaway is strength. During the time that we saw you, this was 4 or 5 years ago, so you were going through things then, but I couldn't tell it.
It's great to hear your impression of what was happening and how I came across to you, because oftentimes, patients don't get that feedback as intimately. We do get the overall, okay, did they spend enough time with you? Did they explain to you what you needed? But oftentimes, for us to be our best, we need more intimate detail. And thank you very much for that, because that's very helpful. One of the things that I did during the time that I had my my diagnosis, there were a couple of things. When I was bald, I wore my wig to work every day, but nowhere else did I wear my wig, because if I was in Target, I was bald. But if I came to work, it was about my patient. It wasn't about me. It wasn't about that experience. And it was about me focusing 100% on what their needs were, and hopefully making sure that they felt that from me. And so I'm happy to hear that you all felt that the information was there, that the focus was there, and that the care was also there. But you're absolutely right. We never know. We always say that, right? We never know what someone else is going through, and what moments, but hopefully what they are bringing with those moments are the best of what they have to give, and share. And thank you.
Good.
Thank
you.
Well, since there seem to be no more questions, what a fabulous day we've had. This is something that is good for everyone, and look forward to somebody actually viewing this tape later and learning the many facets of a profile of courage. And we thank you again, Dr. Wilson, for making this a spectacular day.
Thank you very much, Dr. Callender. Thank you for having me. Whenever you need me, I'm always there. And so if I can ever help in any way or help anyone in any way, whether it is support, advice, or sharing what my experience was, I'm happy to do that. Thank you.
Okay, well, so it's been a great, yeah, we all applaud you and your faith in God and your commitment to love, because it's all about love, and you've demonstrated love in action. So this completes another one of our recordings, and you know, we talked about how we wanted to keep some of these, and so as I asked you to give me some feedback, it does appear that those sections that we have special presentations, maybe a separate category for us to keep, and we'll talk with us about that and other ways of keeping all of the work we're doing together. We talk about our app, and what we haven't talked much about is how to classify the work that Darryl has allowed us to do with documenting what goes on in each of these sessions. Okay, well, thank you very much, and see you again next week.
Thank you.
Okay,
Thank you.
awesome
Thank you.
presentation.
Yes,
Great.
wonderful, wonderful.
Yes, awesome. Bye, everybody.
Bye.
Bye-bye.
Bye-bye.
Have a